Everybody, welcome to Dental Learning Live. We got another case for you. You know what, today we're going to talk about a retreatment case. It's one of those cases where all the traditional anatomy, primary anatomy, is discovered. It's one of those cases by traditional methodologies and traditional thinking processes should have worked. And what happens when it's your own and you're looking at your own work and you're like, this should have worked. Now, in this scenario, it was not my own, but it should have worked. It was a good-looking endo. All the anatomy was found. It's within, a millimeter of the radiographic apex or thereabouts. And you know what? We have an outcome where a lesion grew on the mesiobuccal root. And this speaks volumes as to why we're thinking in terms of fluid dynamics these days, because there is something going on that is still culprit to a problem. Now, this case is several years old as far as from the first treatment, which was a vital case, turned necrotic. So something happened, transpired from the patient's record. There wasn't a new crown placed. There was no evidence of leakage margins. So the assumption is, from the history, is something was going on inside this tooth that we cannot understand. And so we took a cone beam. So let's actually start by looking at this cone beam here. So let's switch this over and we'll get started. So retreat number 14. Should have worked. So first impressions, not bad at all. You can see an MB1, MB2. Everything is, like I said, to the radiographic apex of the root. And we got a problem. You can see there's some sort of rarefaction going on up here. So let's take a closer look. And obviously we're just going to dive in and show you this on a cone beam, that there is in fact something there. You can see it on the cone beam. The first thing I'm actually looking at as I'm lining this up is just going through the roots, and you can see where that's at. You can see the MB1, MB2. Just going to kind of go through all the roots. You can see how they're 2-to-1 configuration over here. So we started with the distal buccal. Now we're doing the mesial buccal. You can see the rarefaction. You can appreciate what's going on there. Just looking in all planes, and kind of what I'm hoping for or trying to identify is, can I see an accessory canal? I mean, that would kind of be cool to identify that up. And my mind can definitely make believe that there is a pathway there, and that's kind of what I'm showing. But is it really? And I don't know. I can definitely appreciate the kidney bean shape. I can see where the 2-to-1 came in, but is it 2-to-1 and back to 2, or whatever the configuration may be? I don't know. But that was the reason for the retreatment. That was the etiology that I identified as culprit to the problem. The patient clearly had the symptoms, was prescribed antibiotics by her general dentist, and was a 10 out of 10 in pain. So this was something, but no physical swelling present in the vestibule or facial. So that was it. Chief complaint symptoms, chief complaint lesion identified on an x-ray, and it was time to do some business. And so we isolated it, recommended a retreatment, and the point is, can the GentleWave make up for good endo? I mean, good endo meaning there wasn't any iatrogenic errors. I have no knowledge. The patient couldn't really remember if it was a generalist or a specialist. She thought she was referred, but she had nothing more to say than that. So I don't know if it was done by an endodontist or specialist. I did do a survey for the AAE and spoke on what that means. If you ask that question, was it done by a specialist or by a generalist, and what your bias were when something looks good, would you retreat it regardless? And the answer, actually, by our own community, 100 people responded to that survey, and they all said yes, that they would retreat it regardless of who it was. And the idea was, if it was a good endo, would you favor an apico, meaning everything has been possibly done inside that tooth, so would you then switch modalities? And what was funny about that survey is everybody said yes to that unless it was themselves, and then they would do an apico. But And I don't know, we're human beings, right? So we're going to access, and I'm going to pay attention through this access if there is something going on inside that crown. Meaning, do I got good margins? The foundation, is it solid? Do I have recurrent decay? And if I do, that might be an influencer both to etiology as well as, you know, the ability to even perform in some cases the GentleWave if the crown is leaking, for instance, or maybe should I cut off the crown. But in this case, so far so good. Things look really adequate inside there, so I like that. Smooth sailing. And right now I'm just identifying where the orifices are. I really like slow speeds in this. These burrs cut really well, so I can cut through dental material, even amalgam with them. It just gives me the ability to see and feather in on top of to make sure I'm not using a high speed and leaning into what I think is the top of a canal when you're not. That would suck, so don't like that. So I like this instrument a lot for this purpose. And we're just going to find the anatomy. Kind of boring for all you experts out there. Quickly I found the distal buccal. Now I'm actually kind of going down and just exposed the palatal. Right there. And these are, you know, fairly, like, even by today's standards and by my own standards right now, I'm not doing this sort of cervical enlargement, but this was previously enlarged, and so I am actually dimpling the gutta percha a little bit. Candidly, the reason why I do that is I like that because when I flow C-form, if you use solvents, some people don't, I do. But when I use solvents, I like to have something to dimple against. So the solvent can actually touch and mix with the gutta percha, and sometimes that's actually hard to do, to get them to mix. And so a little bit of agitation and dimpling with a needle or an explorer is how you get it in there. And so I find if I countersink the gutta percha a little bit, it's easier. It wets it a little bit easier. So that's all I was doing right there. And now I'm just going to go find the mesial buccal 1 and mesial buccal 2. I knew they were all there from the cone beam. Like I said, there wasn't anything. And you know what? With that X-ray, both X-rays, the 2D and the 3D, showed me that I really wasn't expecting to find any discoloration or leakage, or the materials were composite and a crown. And so I wasn't. You know, sometimes when I get into these older gold crowns or silver crowns and different kinds of materials inside, you know, when I get in, access it, I'm seeing all sorts of funky geology going on. They look like different layers of rock inside there, and stainage and colors, just like the Grand Canyon, looking at sediments of rocks. And I think about that all the time. And so when I don't see that, I see things that are very homogeneous in there. I'm always comforted that I'm in a good, clean environment. That, and sometimes the smell, right? And so this environment seems pretty predictable, pretty good. I'm not worried about the crown leaking. And now I'm actually just cleaning up the floor, and we'll get started on the retreatment protocol. And like I said, we all have different tricks of the trade, and I would love for you guys to comment on your tricks. If, you know, I've heard everything from frictional heat, high rotation speeds, to landed files sometimes to really engage gutta percha and pull them out with a kind of a push-pull motion. Some guys like solvents like I do. I've learned to kind of master that and clean it up with isopropyl at the end of the C-form, chloroform C-form. That's what I like. I always like to get it to bite with this, like if you look with this little irrigation applicator here as I'm applying the C-form in there, I'm just getting it to stick and bite, and I'm just sort of pumping it in there, and I kind of like that technique. Get it real soupy. And I'm not worried about the mess because isopropyl shrinks everything up, kind of balls it up, and then that's kind of good for me. It's easy to clean up. So that's all I do. I like it because then I have less chance of getting iatrogenically out of center or off center. It keeps me inside the canal and, you know, ensures that the gutta percha is softer than the dentinal wall and so I can follow a pathway. And that's just kind of the way I do it. Sometimes too, if you use frictional heat and you're really pushing on the gutta percha, I find that you can actually get heavy-handed, especially towards the end or the apices, the radix of the tooth, and push things out or go long. And if you're wanting to use the GentleWave and you go long, that may pose a problem on your ability to use it in certain circumstances. And so I pay attention to that. Now, in the coronal third, you can be heavy-handed in it if you're comfortable with that. That's okay. And then we'll just get going. And it's just going to be apply and repeat, and go around. And so I won't bore you with the time it takes to clean that out, but I am going to show you some of the struggles that I had in cleaning this out. But I'm going to fast forward this. I'm not going to edit it so you guys can see everything in real time. And all I'm doing is I'm going through this instrumentation protocol. I'm using progressively finer and smaller files as I progress through. That's all that's going on here. Still alternating between the C form. And actually I'm finding that this is kind of hard as a rock. This gutta percha is pretty dense. But soupier the better. And now what I've done, once you get to a certain point and you want to kind of clean up some of the mess, sometimes I'll go midway through the removal process of the gutta percha. I'll go right to isopropyl just because I can, and I want to clean up the mess, and I just want to be clean, and I want to really see if I'm getting everything out of it. You know, a lot of times there's just aberrancies in that traditional file shape. Aberrancies meaning some sort of undercut or interconnectivity with the sealer and the gutta percha. And you know what, although the GentleWave can dislodge and disrupt a lot of things, certainly organic things, you know, it can dislodge floating gutta percha, but it really is not going to actually remove the gutta percha unless they have a different solvent or something in there. And so for me, I want to expose the fluid dynamics, since this is the goal of this technique, is using the GentleWave. I want to expose that to as much dent in the walls as I can. So I'm going to really actually try to clean it. I don't want to enlarge it. It's already enlarged enough. It's by a lot of definitions, and by my definitions of today, it's too large. But it is what it is, and it's already there. And so I'd rather wick it out more than enlarge it to get it out, which, you know, is a different skill set under a different mindset now. I think, you know, a lot of us started out our careers where we just enlarged it and just kept going because it was more efficient for us. Now I think different. So I cleaned it up a little bit. Now I'm using smaller tapered files than the wall or the canal prep itself. This for sure was an 06 or greater shape. I'm using 04 files now, and just, you know, apply, clean, repeat, apply, clean, repeat, and go through it, flicking these little boogers out. And there's a lot of files to do that with. You can always go larger files if necessary. If you have something that's being stubborn and stuck on the wall, which I'm going to show you, I did have that problem. But I'm going to stay true to the calling. And right there, I was kind of getting a hint of, you know, was there a DB2 or an isthmus or something connecting back to the palatal? So I was poking at maybe a stone in some sort of isthmus between the distal buccal and the palatal. And what I chose to use to kind of pick up any other fragments of gutta percha that are in there was this 3D Shaper by Brasseler, and I really like that. It's really wobbly. Looks like a hula hoop going on in there. And that's what I'm using to see if I can actually engage any of that gutta percha up on the walls, which you can see I'm dancing with right now. And I'm actually doing this in all 4 canals. Just to see what comes up. You know, a lot of times when we kind of smear it or just enlarge it and just push it into the different, you know, into the diameter of the canal, you could get passively a cone or a file through, but it doesn't necessarily do the job of if it's still clean or if there's something trapped there. And in the MB, I got to be very conscious of that because radiographically, that's where my lesion is. And so I'm thinking through that stuff right now, and I'm going back to some more solvent. And I can see certainly that in the palatal. The gutta percha right there. So I'm not quite done. So we're going to keep playing here for a bit. Pulling up pieces. And at this point, especially in that palatal, it got so frustrating and I just couldn't pick out those pieces and the 3D shaper wasn't doing a job. I actually grabbed an old landed file. And I find that a lot of times those landed files will actually engage that, especially when they're soupy, and that's what I used. You could also just continue to wick it, just keep the solvent in there. You could see what came up now here. But you could use the solvent in a paper point to also wick it. It's another technique. But in this time, I just wanted to use files, apparently. So we'll go ahead and get this all cleaned up. Yep, it's still there. It's frustrating. People don't realize how hard our job really is at times. And certainly when you want to be a perfectionist. But what I'm doing now is it's pretty stuck on the file, and maybe it was the technique that I was employing. But I knew that it was loose enough where I could get an Explorer and I could just start clawing at it and just wicking it off the wall. Once I created that separation from the wall and gutta percha, I went back to solvent and I just danced with it again. Kind of off screen a little bit because I'm just dancing with it, so it's hard to show that in the mirror. But I'm just wicking it, I'm getting it soft, and we're going to keep playing this game until I get it out. Sometimes this can be the longest part of the job. And at that point, I went back to a 3D shaper after I was danced with it enough to where I felt like it came off the wall. And then just going around one final time since I put solvent everywhere, I'm just seeing, sometimes I think I'm clean. And I'll do this technique at the very end with this 3D shaper and more solvent. And sure enough, I'll be pulling up more sealer and I'll be pulling up gutta percha even when I don't acknowledge that it's there. And you can always do a check film. You can see I still got the gutta percha flowing on my section there. And then, sometimes I go back to the solvent at the very end just to triple check myself. If I start seeing clouds of pink come up, then I know I still got some gutta percha somewhere hidden inside that anatomy. So those are my techniques. I mean, it's trial by error, and it's a lot of trust but verify, and passing files again. And it's certainly down at this level when I'm down to the terminus. I don't want to go long on this. I just want to go to where the gutta percha was to the best of my ability. Tactically, you can feel it. When you got the bulk gutta percha out, you can actually feel it bite at the end of those files. This one's a 1504, and I am getting a little bit of pinching and grabbing of some softened gutta percha down there. And I also know my lengths. I like, when I do this, I'm actually using a calibrated file, obviously, and I'm measuring on that cable surface margin, which is kind of hard to see, but I'm actually coming down to the margin here with that file, and that's where even though it's going fast, I got a lot of muscle memory in my fingertips, but that's what I'm looking at. That's why my mirror tips to the side, because I'm actually measuring every one of those bounces. I'm actually measuring, so I'm gauging where I'm at. And now I'm going up a little bit. Now that I'm not getting that little bite down there, I'm actually just going up a little bit with the file. I'm not trying to engage the dentin. I just want to make sure passively there's no more gutta percha. And if you look at my file, I just found gutta percha by true to form, trust but verify. I just verified actually I wasn't as clean as I thought, and by so doing, there was gutta percha. And this is very, very important because I'm on the MB1 and MB2, and there again, just to remind you, that's where the lesion is. And so that's the thought process. And I'm just sort of self-validating with stories in my head as I'm working to make sure I stay engaged and stay focused and do the job that I was getting paid to do. And in this case right now, it's remove all that gutta percha. But tedious for sure. Still see some of that in there. Now this one's in the palatal, but it's still there. And I'm just kind of jumping ahead. Showing that I got everything out now. Got that last little piece of gutta percha out of the palate. MB1, DB, MB2 up in the upper corner. There we go. Okay, so we're done, right? Or we've just begun. Done removing the gutta percha, but we've just begun the battle because now I got to remove all the bacteria. Whatever's inside in that apical third that caused that rarefaction, now that's the job. I'm employing the GentleWave for that. So you saw me put my breadcrumb in, I put my sponge in, and at this point, I'm just glopping on the sound seal. I'm making kind of a donut around it. I like to peripherize the tooth with the sound seal. I'm not worried about leaks. I'm more worried about stability. The patient needs to move if it's, some people are gaggers, or if the tongue's gonna play with me along the way. I mean, this patient's really compliant. It's fantastic actually, but I build them all for failure, right? I build them so they can withstand the storm. I don't want to chase the storm. I want to withstand the storm. So if the storm comes, meaning patient movement or clamp slipping or whatever it may be, the storm, I want to sort of prepare for it as I go into the case. And that's my logic as to why I really create a stable sound seal platform. Very important to me. Because when you start doing hundreds of these, man, it's just, it's not fun to rebuild. I hate it actually. So I just want to build one time. And I'll cure over the top. It's excessive. You don't always have to do that, but when you use bulk sound seal, you do, as I do. I go through that stuff like it's water. And then I just grab a file. This is a landed file. It's easy to pop the cork, pop the breadcrumb out, and there you go. Kind of a nice impression of that matrix. I'm going to redefine my access, look for air bubbles. I've gotten to the point actually not to be such sort of a cake decorator or a finished carpenter in sort of decorating the sound seal around, and voids are a thing of life and they happen, but they're almost easier to fix than they are to worry about if you create them. And it's just, I'm sort of measuring my time of both those statements. And for me, it's actually quicker just if they exist, then fix it. And I kind of have two sound seals on my tray. One to do the bulk apply and one to do the patch. And if I need it, the patient, my assistant hands it to me. So I needed it here. And you don't appreciate that. And I'm flipping that up for demonstration. I don't always have to tear through the lid of it. But yeah, I had a nice impression, but there was a big hole underneath. And the cable surface margin was fairly closed. But I just want to patch everything if I can. And it doesn't take me but a few seconds, and as you're witnessing. So I patched myself, great. But, you know, I'm only 2-3 minutes into these builds, and it's no bother to me psychologically or emotionally when I do it this way. To me, it's always a logical progression forward, and I'm happy in that space. So I've stopped sweating the stuff that I don't need to worry so much about, and being so picky, which I did start out that way, by the way. I always wanted that goal to build the platform right the first time, and I've said that, and I may have even done a video saying that. Because I say that to myself all the time when I do my endo, and I was saying that to myself when I'm doing my sound seal. But now, when I realize the the forgivingness of just sort of reapplying this conforming resin of Sound Seal, man, it's just so much better not to sweat it, build it, and if it's there, fix it, because it's a 2-second fix. It's a lot easier. I remember in like the dental school days when we were waxing teeth, at least I had a waxed teeth, you know, and I would try to build a tooth up just perfect. And it took me a lot longer to build up than just whittle it down. Overbuild and whittle down was a lot easier at the end of the day. And that's kind of my mentality with Sound Seal. Overbuild, whittle it down, or reapply if there's a bubble. Now, I talked through that stupid story on the selection of the cap, but I don't want to neglect that statement. So there's been some talk about, well, you know, naturally, depending on the depth gauge that you pick, the sound bar is a little bit shorter by design. And so, you know, if you flick the floor, do you pick that same one? Or if you flick the floor, do you go down one size? And that's a debate. And we know that the company says 0 to 2 millimeters, really. But the reason why we don't want 0, meaning touching the floor, is just patients can feel it, and it's a little bit disturbing. So you want it to hover as close to the floor. And there's no doubt that the physics works better like that. But up to about 2 millimeters or so, it's the same efficacy from their research, from what they've told us. So there is a range, and they may actually change that range. But right now, that's what we have to work with. And that's what I subscribe to. So for me, I'm always a patient comfort guy first. And so I will, and I'm also heavy-handed when I measure by design, because I'm pushing on it. The platform that I created with the Sound Seal, because I want to know if I can dislodge it right now myself. Because if I see any like micro movements going on under the microscope, I abort. I don't want to use that platform anymore. I'll rebond it on. I'll figure out a hack to do that, but I don't want to do that. So I push down really hard, and if I'm pushing down really hard, I actually want to really feel the depth gauge hit the floor. And if I do that, I'm likely bending it, or I'm really scratching it. And so for that reason, I go one shorter. That's my logic, and I've sort of adopted to that, and it works great in my hands. I don't know if that makes sense to you. I hope it does. But the idea is, if this is my floor, I take the depth gauge, I'm really pushing on it, and there's probably some bending going on. And I'm also moving it around forcefully, because I'm trying to move the top of that Sound Seal, because if it dislodges, I'm not going to be happy, and I want to know that before I begin. Some guys do the perio probe, but in that perio probe, you know, it might find different depth heights along the floor, and it's really hard to scratch all across, and my hand might go up and down if I measure. And so for me, again, it was like easier and faster just to go tactilely than visually in that, for instance. And that's my logic. Now, you've probably seen my videos before, and that's an explainer video that I didn't talk through. But I wanted to really focus on those other principles because I haven't talked as much about that. But the GentleWave technology is real, and the fluid dynamics are real. And it is generated in this procedural instrument. And as such, I feel steward of that procedural instrument in my hand. I want to keep it on the tooth, and I want to watch it. The more that I do this, the more that I realize I learn there is feedback in that. And we get haptic feedback. We learn from the sound changes. We learn from changes. But we're human beings, and sometimes we get distracted. We might see, you know, something run across the room, or, you know, squirrel, and look over there, and then not pay attention to what we're doing. And you'll see that happen here. I'm going to fast forward until I find that episode. And I want you to actually look down here at me when I'm going through this. Don't look at my ponytail, but just look at, I'm talking to my assistant right now, right? Things are smooth sailing. And let me go back. Watch what happens. So if I go back here, watch my head, I'm talking to her. And subtly, squirrel, right? I just kind of look away. And what happens is, as I'm doing this, pay attention now as I move, see what happens here to my procedural instrument. Or sometimes the patient moves on me and I'm not paying attention to follow with the patient. Okay, so I'm actually looking, talking to her as she's typing her notes, and I'm actually dictating to her what to write, to be honest. And look, this thing started flooding, and wasn't a leak, wasn't anything wrong. It was like, oh, Lindsay, come assist, you know, come suction. And I just repostured myself. I just started drifting. And sometimes I found, like, if your chair's not locked and you're doing that kind of stuff and your chair is really loose like mine, you can actually drift the patient's chair away and you'll get these sort of natural elevations. And so that's why, you know, it's really recommended. That's just human. You're just a human being. So it's really recommended to always don't freak out if that happens. Just suction and then just sort of re-posture on that and see if it just reestablishes itself. And the difference is there's no bubbles or foaming. It wasn't like I caught a leak. I just had enough of a surface tension break along the sound seal to let that sort of pool up. And you'll notice that there's difference. They sound different than when you're discovering an air leak inside or seeing a foaming bubble inside. And I think as a compensation for that, I'm getting more lighter-handed. I think when I started out, I was very heavy-handed with these things. And maxillary, that's fine to be heavy-handed because it just kind of lifts the patient's neck up. But if you're working on a mandible and you're heavy-handed so you don't worry about leaks and whatever, you're pushing the patient's chin down, which essentially closes their airway, or they makes them swallow their own tongue. So don't do that. We want the chin lift, right? So I've learned to start to find that sweet spot to where the negative pressure kind of keeps me on board, and I'm getting more and more delicate on how I posture. I don't grip it anymore. I don't hold it and I don't force it. But the consequence is you got to concentrate because I'm finding that balancing act. And when I deviate like you saw, I'm just going to pull and then I'm going to really correct myself very quickly. The nice thing the way that we all probably have our own rubber dam techniques, but on my technique, you know, I'm using Orasil, rubber dam, and then sound seal. There's a triple decker layer there, right? Triple decker sandwich going on of different materials to be a barrier so the patient does not taste bleach. Now, taste your own bleach. Then you'll know why you want to be a Boy Scout and make sure their patients don't taste bleach. Because if you're not compassionate there, it sucks to have to taste bleach. It burns. And in patients, you should really have empathy and do your job so patients never have the chance to taste bleach. Soapbox, I know, I'm sorry. Okay, well, we're gonna run through the cycle of hypochlorite, then water, then EDTA, and then water. And you guys likely know the time. The console does the magic, degasses the fluids, puts it through the procedural instrument, adds the fluids to the tooth, degasses it, cavitation occurs, creates the mechanism of action, cavitation cloud, those bubbles expand, contract, creates sound waves. Bernoulli's principle going over an empty space, meaning the canals, creates negative pressure. So those are the mechanisms of action physically. Then we have chemistry, and we say advanced chemistry only because of adding the physics to it and accelerates it as an accelerant. And those are essentially, in a nutshell, how GentleWave works. Now, I want to employ that at the terminus, clearly, because there wasn't any signs of coronal leakage and there wasn't any signs of bad endo, or iatrogenic endo, I should say. And I didn't see any smelly muck coming out of that. It was just gutta percha and solvent cleaning out of that. And so now it's very important that this sort of theories, these fluid dynamics and these principles are applied at the terminus of the tooth. Okay, so we're done, and you can see that things look intact. The sound seal did its job, and now I'm going to take this off and just sort of show you the undercarriage here. And you know, I do that just for stability purposes, and you know, if you have a good seal the whole time, you did a good job with employing the protocols correctly. I like to see bleeding. I don't want to see excessive bleeding, but I want to see some bleeding because then I know I got to the terminus, actually. I gave the apices and a hickey, actually, and I'm good with that. I like that. I want to stir that pot, so to speak, in the sense of letting the demons out. I want that infection gone if it's extra radicular like this one on the MB. Now, I use 3% saline to help initiate the arrestment of the bleeding. And I'm sort of gauging my cones. I'm guesstimating and placing my cones and they're calibrated, and the advantage of that in these sort of greater tapered canal shapes previously existing, don't recommend it first time, but this is a retreatment. I use those because then I can kind of gauge where I'm at and make sure I'm not going long or that I haven't instrumented long or whatever. And I was successful with the GentleWave, so I know I didn't instrument long, but you can see where I'm at all along in each route. You can see true 2 canals in the MB, you can see the palate and the distal buccal, and I'm comfortable. They were my lengths, and I do believe I may have advanced a little bit on the MB. Advanced meaning just increased actual instrumentation length on that, but nothing's out. Okay, so now the rest is going to be up to expose that with my obturation technique, and my hope is I'm discovering something, that I'm going to see something, fill something up. My belief is the fluid did its job and cleaned something out, certainly or hopefully in the mesiobuccal. Now, hindsight will be 20/20, as it is always. I'm not going to know if this is successful until I get my recall. But I've been at this long enough and done enough recalls that I am getting very, very confident that it will. And so I will have to show you a recall, since I just did this case, resolution. And I'm going to show you resolution of this, or not. If it doesn't work, I will show you either way. But this is one I'm going to follow up with you all on and see, because I've gotten a lot of questions on that and people wanting to show that. And so thought, what's best than an aged, good endo gone bad, good endo that didn't work, and can we make a difference? And I got enough cases in my arsenal to say yes, but rather than do hindsight 20/20 in showing you radiographic resolutions, I want to show you treatment resolutions via video. So that's the point of this case. I'm just drying this up as I was talking. Nothing crazy, just drying it up, wicking everything out. Getting to the end of that. Like I said, I'm really hyper on that MB1 and MB2 because I know where that's the crux of my problem. But I'm looking at what's coming on these paper points through all of them. Want to keep them dry. And once I'm comfortable with where I'm at, I do an injection. Everybody seems, at least there's a modality to go to bioceramics, which is right. I'm doing that as well. You see the sealer coming up, the MB2. I do still like ribbon a lot, or H+, epoxy based, I guess. I've been a fan of that for years, and I still have that as a carryover, but I find myself really using BC more and more and more, especially with the GentleWave. So what just happened is I pulled the cone. I'm sure we've all done that before. So I pulled the cone. If I pull the cone, I'm going to reapply my sealer. I'm going to do it again. But I usually will go up a half size. So I was at a 30, now I'm at a 35. Why do I do that? Well, that's my protocol, because why did it pull? If I didn't create it with the down pack and heat, if I didn't actually create friction on that, then I'm going to go up in size to try to generate a little bit more. And that's what I did there and why I did it. I'm actually wicking out the sealer out of the MB2. Basically, if something pushed through, I want to wick that out if that was extra fluid. That's my logic, right or wrong. And then applied some sealer in the MB2 and now a cone. And I knew on the CBCT it was just 2-to-1. And I also knew in just instrumentation they were 2-to-1. But I'm hoping it's 2-to-1 to 2, right? If you go back and study that CBCT, I'm looking for something extra in there. And make believe or not, I want another canal to be there. And so I'm not going to know that right now unless my fluid did the job. So that's what's in my mind. Okay, now I'm off to the DB. The technique of obturation to me is, I'm kind of developing this little subculture of obturation techniques and based upon the size. Like when I'm in a retreatment, it's it's greater taper, they're 06 or greater, and they're big spaces in these retreatments. I'm doing more of a true continuous wave where I am applying heat and down pack. And at times, those are some of the scenarios where I'll favor epoxy-based sealers, actually, because I don't like activating these bioceramics with heat going down deep. I haven't been a fan of that on the way the obturation feels, performs, and looks in my hands. When I'm at slender sizes, when I'm like being a minimalist and I'm employing the GentleWave and I've got my sizes really small, 1504, 2004 at times, maybe 1506, somewhere in those ranges, you know, and those canals were calcified to begin with. They're very slender and very tight. I'm actually, for sure, always using BC in those situations. And I'm actually doing more of a cold technique, cold condensation, because I'm getting a true fit of a cone in that. And I'll backfill the whole way up, and then I'll place a fitted cone that's a true fit, meaning it's really intimate. That shape and cone are married. And then I actually sear it off the orifice and do a cold down pack, cold con. Kind of like the little lateral condensation days, but with just sort of a wedge force plugger pushing directly on it and forcing it in. And you'd be surprised how far your sealer goes in that. Like, it's a true plunger effect. But it's very effective in those smaller sizes to obturate smaller and smaller spaces. I really like that technique. And so I don't use like a ribbon sealer in that scenario for those reasons. Because if I am going to get extrusion out the tooth or fireworks, I don't want it to be an epoxy based. I feel more comfortable with like the bioceramics in that scenario. So I've kind of developed these little, and then somewhere in between, it depends. And so you just, as you do more and more and more, you start teaching yourself these little tricks. And I would love to hear your tricks, actually. Why don't you guys share with me some of the things you do? And does size matter to you in obturation? Now, after I've done that, I'm going to clean that up with alcohol. Watered, rinse, dry. Things looking clean. You know, there's always a joke, early on, I think we've all been there when we've done a traditional pre-GentleWave sort of retreatment. You feel good about everything, and you get to this step, and your assistant comes by and blows air. And then all of a sudden you smell that necrotic odor again, and you're like, what in the heck did I just do for the last hour of my life? Why do I still have that smell? And maybe I'm a Scentsy guy. Like I like good colognes, fine colognes, and I don't like odorous teeth. Odorific's not good in my book. So I hated that. And then I would always feel compelled to do more. And what I found since I've adopted the GentleWave, I don't run into that. It smells like Mr. Clean. Like he's cleaned my kitchen floors. Like it just has that clean smell. And doesn't mean much. I get it. It's anecdotal. But it does mean a lot to me when you're trying your best to save a patient's tooth or get it to respond, to heal, to resolve. I know it's dumb and fun. So after that, I did a bonded technique. If you watch my videos, I'm using the same technique you've seen before. It's a two-step bonding protocol with a conditioning agent and then the bonding agent with a light cure. And then I'm using a comprimer, dual cured comprimer inside this crown. I've had a lot of years with this product, so it's weathered the oral storm, and it sort of weathered the storm of the junction, the marginal junction between the crown when you restore it with a crown. The crown's existing and you're trying to get your buildup material to bond to a crown wall or to weather that storm. And you would know that by stainage or leakage and kind of recalling and talking to your GP. And with my GPs and my referral, I've had really good feedback with this product, so I've stuck to it. I do a tertiary and some of these pure zirconium crowns. I don't know about that scenario, and so I've learned to do a comprimer buildup, and then in the last millimeter or so use a different bonding agent and material, composite material, actually to bond to zirconium. This was not, so this was a little bit different, but something for y'all to think about when we want to blame our own failures on coronal leakage, which I could not do, by the way, in this scenario, and it wasn't my own. All right, well, so here you go. The before and after, you can definitely see, let me pause this for a second. You can definitely see some differences here. Now, where things are whiter, like here, these are connected. These are connected spots. And sometimes you can see some voids or just less dense areas in there. But you can see that we did shoot something out to the side off of the main canal. And this was the make-believe spot I thought I saw on the CBCT. And it proved to be there. And as I continue to study, I see some uniqueness both to the palatal as to the distal buccal, but primarily this was my goal. So time will tell how true that is. I do know I filled something. I believe I cleaned it, and I say that for you naysayers out there, but I do believe it is cleaning as we're taught and as I've witnessed throughout my practice with this technology. And so to be continued for this recall. And that is it. What do you guys think? Another retreatment case down. Hopefully you guys find this somewhat useful. And you know what? I've been getting comments and direct emails, and that's been fantastic. I would love to start a thread of people's retreatment techniques. So it'd be fantastic if you guys would share your protocols, the instrumentation, RPM speed, solvents, or whatnot on your retreatment protocols to stay centered and to not over enlarge. Those are the goals. So love to hear from you guys. Thanks you for attending. Until the next time.